Open the meeting, you're all very welcome. Just advising members to switch off all electronic devices. With the exception of the tablet, there has been a number of issues around interference with recording equipment, so please pay attention to that. I have apologies from Fergal McKinney. Just briefly under Chair's business, just advise members, you will be aware Mickey Brady has resigned as an MLA with effect of 3rd of June 2015. I'm suggesting that we would write to Mickey on behalf of the committee, thanking him for his work. Members in agreement with that, thank you. Also just want to refer members to page 3 of your tabled pack. Officials were due today to brief the committee on the department's core funding for the community and voluntary sector, which was agenda item 5. Officials will now not attend as the Minister is still considering how best to take this matter forward. He is due to meet soon, as the notification has indicated, with representatives of NICFA to discuss central funding, and once he is clear on the way forward, he'll make arrangements to update the committee. Obviously, committee members have expressed a keen interest in making sure that there is core funding, and any sort of reform or review of core funding is properly consulted on in terms of the impact that it very clearly delivers across many organisations and sectors. So I'm asking members at this stage to note that correspondence.
Chair, could I just say I'm a bit disappointed, because as we all know that the community and voluntary sector are at us all to try and get decisions made as soon as possible, because they can't plan anything until that's done. So perhaps the urgency of the issue might be referred to the Minister in his department.
Yes, I think that goes without saying. There is an urgency to this. I would hope, however, that given the fact that the Minister said he's still considering options, that there is still room to have the right outcome in relation to this. So I would make that point also. Just also want to inform members that the Department has still not confirmed a date for the Minister to attend a formal meeting of the committee. I have to say I'm disappointed with that date. Can I suggest, members, that we would write to the Minister just expressing the need for that meeting to take place ASAP and look at possible dates.
Great.
Okay, item 3, members, is the draft minutes of the meeting on Wednesday the 3rd of June 2015, which are page 6. Just refer members to page 6 and ask if members are content.
Great.
Okay, members, item 4 is the committee review of workforce planning in the context of transforming your care, a briefing by the Scottish Government. Just want to refer members to page 10 of the meeting pack and page 5 of the tabled papers for your relevant information. Again, advising members that the video conference session with the Scottish Government officials will be conducted via the broadcasting system. So I would ask members to remain as quiet as possible, obviously not when you're speaking, and whenever a question has been asked of an official, to avoid interference in the feed. I would also ask members to introduce themselves before asking one question at a time, and probably to do so in a more slower pace than normal to allow for any slight delay in transmission. So if I could, I would just like to introduce Ms. Shirley Rogers, who's a Director for Health Workforce, Professor Ian Finlay, who's a Senior Medical Officer, and Mr. Grant Hughes, Head of Workforce Planning. You're very welcome, and we're pleased to have this communication today. I'm going to invite yourselves to make the opening presentation, and then we will open it up to members' questions or comments.
Thank you very much indeed. Can I just check that you can hear me okay?
I can.
Thank you very much, and thank you for the invitation to speak to the committee. We're delighted to be able to participate in the context of the review of workforce planning you're undertaking in transforming your care. You've asked us to give evidence about how we developed Everyone Matters, our workforce vision, and the strands taken forward.
Can I just stop you for a second? Just do we check our sound levels here? It might be our end. Can you go ahead now and we'll check that?
Is that better?
Yes.
Thank you. We're delighted to share that with you. And I was just going to briefly touch about how we formulated the work that we've done, and particularly concentrate on some of the sustainability and workforce planning issues, which I think are a particular interest on you. Our workforce strategy covers NHS Scotland, which is 159,000 folk. It supports a 2020 vision for health and social care in Scotland, which is essentially for everyone to live longer and healthier lives in their own homes or in a setting. So underpinning that is a healthcare system which has integrated health and social care, a focus on prevention, anticipation and supported self-management. Within that, really a shift in our future direction of travel that is much more about community-delivered services. So when hospital treatment is required and can't be provided in a community setting, then case treatment should be the norm. Whatever the setting, care will be provided to the highest standards of quality and safety, with the person at the centre of all of our decisions. And there's a particular focus on ensuring that people get back into their home or community environment as soon as is possible, with minimum risk of readmission. So we're looking at those issues very carefully to make sure that people are appropriately returned back home, and we're monitoring the impact on readmission. Because clearly it's not in anybody's interest if we've got patients who are sent back out of hospital only to return in quick order. Our 2020 workforce vision is about responding to the needs of the people we care for, adapting to new, improved ways of working, and working seamlessly with colleagues and partner organisations. Continuing to modernise the way we work and embracing technology, a huge thrust on technology in Scotland. We have a very concentrated population in our central belt and areas of Scotland that clearly have a huge remote rural aspect, not dissimilar to yourselves in that way. The values that we share across NHS Scotland are about care and compassion, dignity and respect, openness, the sorts of things that you would expect to see. And this vision has been co-produced with our workforce. Everyone Matters had an extensive engagement exercise. Over 10,000 NHS workers in the first year contributed to its creation. That discussion has continued with similar numbers each year. And the format for that strategy is that we produce something that we have an annual implementation plan for, and we hold our board to account for that implementation. And you may wish to talk to us a little bit about how we do that later on. 5 key priority areas: something about culture, sustainability, the capability of our workforce, what I've just described, significant change, and we're supporting our workforce to be able to have the skills and confidence to do that. Big piece for us around integration, not just in terms of health and social care, but also primary and secondary care, and effective leadership and management to make all that come to fruition. We produce an annual plan, and we're just about to be able to produce the first annual plan that will demonstrate how this approach has had an impact in our system. And some of that has been quite interesting and quite transformative. I suspect the bit that is particularly of interest to the committee is in that space around sustainability, and particularly around how we've used workforce planning to do that. We have a sustainability and 7-day services task force under ministerial direction, which I chair. Hugely important area of work, which has the potential to make significant improvements in care, because it's about service redesign to create excellence, to create services for patients in a manner that is appropriate to our vision, but to ensure that we're doing so in a manner which is sustainable in terms of our workforce. We would recognise, as anybody would, that the NHS already delivers a range of services across 7 days. However, we accepted that we couldn't and should do more to ensure that those services are readily accessible across the weekends, that we don't get dips in performance and we don't get this sort of characteristic Monday morning high levels of activity because services are available over the week. Sustainability, as I said, written all over it. That is the prize of our workforce strategy. We recognise the particular challenges of sustainability in remote and rural Scotland, a lot of activity in that place, and we've also been looking fundamentally at the sustainability of rural general hospitals. And there's been some really interesting early success in that area. It's not a quick fix, we know that. It's a complex piece of work, and some of the changes it will lead will take time. We had an interim report from the task force that went to Parliament earlier this year, and Parliament endorsed that, and we have an action plan that we're taking forward in respect of it. Workforce planning has been a real key focus in our work on sustainability. And essentially what we are trying to do is to put some science and some really robust data into what had previously been the art of workforce planning. We're working with a range of stakeholders to improve on the established models and processes. We're keen to identify workforce risks earlier in time, and to make sure that instead of those risks coming to us as a surprise, we've done sufficient analysis to be able to adjust our pipeline to give us a ready supply. We've worked very closely with HR directors in boards and with medical directors in boards to put this in place. And we've now established a community of our workforce planners across boards, which government leads, to make sure that all of the boards are supporting government action and vice versa in respect of it. So a lot of work around developing better intelligence. We've now got medical specialty profiles for every one of our acute hospital-based specialties, and we're just starting to do the same in respect of our GP workforce, so that we've got all of the supply chain that we need in order to make that happen. It's not restricted to medicine. We're doing similar work in respect of nursing and AHP workforce. We have a significant amount of work underpinning that in terms of nurse workload profiling work, so we know what kind of numbers of nurses we need in particular specialties, in particular wards even at a particular time. So some of the stuff that we have been using to yield that information, medical training establishments, preemptive, targeted and strategic approaches to management of rota gaps and service pressures, working much more intelligently, I think, around recruitment processes in our hard-to-fill posts, taking forward the transition to the shape of training, which you'll be aware of. I'm sure other people have spoken to you about Greenaway, and making sure that we've got appropriate information to be able to feed into other processes, such as migratory advisory in terms of shortage gaps and so on. As I say, we've got all of our hospital specialties now profiled. When I'm talking about profile, I'm talking about the consultant workforce that we already have, and all of those trainees and medical students, indeed, who are in the pipeline, who are coming forward. We've focused a lot on some of the key acute specialties, including emergency medicine, anaesthesia, intensive care, clinical oncology, psychiatry, radiology, that kind of stuff. But we've also developed profiles for newer specialties such as intensive care medicine, joint infection training, and so on. And as I mentioned, focus for 2015 is on the GP medical workforce. We believe that sustainability is going to be delivered through different service models and through our ability to craft a workforce that is genuinely multi-skilled, multidisciplinary, as appropriate, not just in terms of health, but also in terms of our local authority colleagues and others working in the voluntary and independent sector. I think, if I may, I'll probably stop there. If I can go back through all of the five priorities of Everyone Matters, if that's helpful, but I think your committee is concentrating particularly on workforce planning. And if that's helpful to you, that's great, and we're very happy to take whatever questions you might have.
Thank you, Shirley, for that. And apologies, we probably missed a bit at the start. The sound wasn't great, but it's improved in the last while. So just be mindful of all of us here too, just speaking clearly and into the mic. So apologies, Shirley, if we go back and ask you a question that you have already dealt with, but please bear with us. Just particularly interested in the planning guidance for workforce planning. You talk about that being that workforce planning is a statutory requirement that was established in 2005. Can you maybe give us more detail around that in relation to who monitors its compliance with the law?
Okay, if I give you the sort of general parameters of that, and then I'll invite Grant to put a bit more of the flesh around that. Our relationship with our 22 boards is very close. We have a requirement on boards to produce something called a local delivery plan. They do that on an annual basis, and that is essentially their contract with government. So when we receive that LDP, that gives us an opportunity to talk to them about budgets and all that kind of stuff. We have an annual accountability process with those boards. That accountability review is generally chaired by a minister. Sometimes not if it's a small board with not that many issues, but almost all of those accountability reviews are ministerial reviews. And in the course of that LDP process, which includes workforce planning, we will go through with the board all of the issues of concern that they may have, development plans, and essentially their plan for ensuring the sustainability of the delivery of that service. The guidance that underpins that is produced in something that we call Chief Exec letters, which is essentially our instruction from our Director General, is also the Chief Executive of the NHS in Scotland, and he issues those letters that cover how we expect boards to do that, and we will go back to them if we believe that the plans that have been produced are not sufficiently robust or not sufficiently detailed for us to be able to make an assessment. So we sign that off as part of their sort of contractual is too strong, but contractual arrangements with the Scottish Government. Grant, do you want to talk through the specifics of the statutory bit?
Yeah, thanks, Shelley. Hello there. I'm Grant Hughes. I'm head of workforce planning. I'm, I guess, responsible for ensuring that the boards adhere to the guidance that we've put out, and the most recent of that guidance you have a copy of. That is in what is known as Chief Executive Letter 32, 2011. So regarding the practice around that, it is mandatory that boards have to provide us with workforce plans, and it has been mandatory for a number of years now, about 10 years. There's quite a lot of background given in that Chief Executive's letter, the guidance which accompanies it, but if I can focus in on one or two things that might help members understand where we sit on those areas. So we play a monitoring role within the Scottish Government in terms of our requirements on boards to provide workforce plans and also 3-year projections, and part of that is around the local, the service planning process, which they are required to fulfil by the Scottish Government as well. And as Shirley mentioned, Everyone Matters, which is the overriding policy strand that we deal with. The implementation framework for that is also something by which we hold boards to account. So workforce planning is integral to all of that, and I think that's what the guidance in CEL 32 covers. And we give boards guidance on that in terms of a methodology about how to workforce plan. We give boards tools to enable boards to match their service requirements with the right workforce. For example, on the nursing and midwifery workforce, where we currently have some groundbreaking tools which are helping boards determine what their future workforce needs are for the nursing workforce. And so what boards provide to us is evidence about what they're doing and how that links to service planning. I'll stop there for the moment because I'm conscious that I could probably go on for quite a long time here. I don't know if members have areas that they would want to highlight in particular.
Well, thanks for that. I'm just wondering, given that workforce planning is statutory, has that raised the profile of workforce planning within government?
Absolutely. Absolutely. We publish national workforce statistics on a quarterly basis in February, May, September, December. We use that to ensure that the boards are being absolutely cognizant of our direction of travel. So there are certain things that we're now starting to be able to look at. Spend in the primary care world, for example. If our objective, as I said at the outset, is to have more services provided on a community and primary care basis, it follows that we should be spending more in that area. And so we look at how we are allocating resources from the centre. We have comprehensive plans around doctors, nurses and midwives and AHPs, and we subject those to quite considerable levels of scrutiny, both as entities in themselves and to see whether or not there are sufficient of each of those groups to be able to provide multidisciplinary teams. The profile is extremely high. It's also demonstrating government's commitment to sustainable health services, so it comes in for a great deal of public scrutiny in terms of media scrutiny and so on as well. And it runs alongside certain other of our commitments about supporting our workforce in an appropriate way to adapt to change and to make sure that they are invested in the appropriate ways around training too. So workforce planning is as high profile as it gets, and as the Director for Workforce, which is everything from how many people we allow into med school in the first place to pay, pensions and everything else, including uniforms and standards of conduct, workforce planning is probably the thing that certainly the thing that I would put at the top of my job description in terms of the things that we absolutely have to get right.
Okay, and thank you, because that's very clear. Did somebody want to comment there? No. And for ourselves, I suppose, what we're struggling with is that we have a policy direction in terms of shift left, and we're only now some 3+ years into the policy direction looking at the area of workforce planning. So I'm very interested in your clarity around workforce planning as a statutory requirement and how that's assisted in terms of the profile and monitoring and priority that it's given. But also, if I may, one of the issues that was very apparent, and it was also apparent when this committee visited the Scottish Health Committee recently, was the area of partnership and cooperation. And I noticed that your workforce vision stated that it had been formed by 10,000 people, including NHS staff, trade unions, professional organisations. And I'm very interested in that model, but also I suppose the question for me is, who was the lead in charge of that overall vision and strategy? Or who is the lead in charge of it?
Okay, the easy answer to that bit first. The lead responsible for the formulation of the workforce vision is me. It was me at the outset, and it continues to be me and my team. Taking those other two issues, fundamentally, whatever you want to do with health and the delivery of health is dependent upon, this is the blindingly obvious I'm going to say, so forgive me if it sounds blindingly obvious, is you've got to have a workforce to be able to do it with. So workforce planning was the first objective of that vision, was to make sure that the people of Scotland were going to have a sustainable health service because we had enough people to be able to deliver it. And more importantly, perhaps, because a lot of this agenda is about changing the workforce, not just about adding to it, was that we had a workforce that was flexible enough and could be planned enough to be able to deliver sustainable solutions. So our approach has been that workforce planning is a bedrock thing from which you can vision, as opposed to a second order thing that you come to when you get to it, because you can't do it without it. The partnership approach is something which is deeply embedded now in the way that NHS Scotland does its business. I am a workforce director within the Scottish Government, but I have previously worked in a board, and our relationships with the boards are very strong. Our partnership model is very strong, and it's not fluffy. It's not about we engage with people because we want them to feel that we're engaging with them. It's about saying we co-produce with you because you have responsibilities in this space as well as we do. So we take it for granted that we will engage with our workforce, we will listen to them in terms of the particular issues that they have, but we will also seek responsibility from them in terms of the implementation. So if I give an illustration which is not solely in this space, we have a no compulsory redundancy policy in the NHS in Scotland. The price of that is that we expect people to be flexible in order to allow us to manage service change. And that works for us. We're strongly in the space of co-production. We spend a lot of time working with our trade unions to do that, but part of the benefit of that, apart from the fact that they're the front line and they know some of the stuff that's going on, but part of the benefit of that is that we expect them, when they're co-signatories to something, to also be part of the implementation of that, and that expectation is very high.
Thank you. Now, there's a number of members have indicated, so I have Rosie first.
Okay, very Margaret Caroline, thanks very much for the presentation. Can I ask you about the shift left, if that's like what actually happened in Scotland, if that's how you'd describe it? Because here we have a policy known as Transforming Your Care, and it's an overarching roadmap for change in the provision of health and social care services, and the aim of it is to provide more care at home or in the community, and to reduce the amount of care required in hospitals. So was it a similar attempt in Scotland to shift left?
Yeah, we don't use that expression. So I know what you mean by that. I think the commonality of it is quite tight though. Our premise is that healthcare for an ageing population is, and to ensure that that ageing population is able to age as healthily as possible, is best delivered in community settings or at home. And as a result of that, we have shifted, or are in the process of shifting, some of our resource to be able to do that. It's also a feature of how we're designing specialist services, because we recognise that Scotland can't have all of those high-intensity specialties in every town, particularly in rural Scotland. And what our commitment to our population is that for heart-lung surgery, you will go to the Golden Jubilee Hospital in the west of Scotland, because frankly, a population of 5 or 6 million people wouldn't sustain a heart-lung centre in every town in Scotland. But the price of that is that you will have enhanced community-led and other services in the place that you live. So it's about having high-end specialties where we need them, but the quid pro quo with the public is that for those things that you don't need that kind of high-level intensive acute therapy for, we will make sure that you've got sustainable local services.
Okay, and I was going to ask you about were service delivery models required, and had these been developed? But clearly that's the case. Can I ask you then, were the service delivery models in place before you started to look at the workforce and the workforce strategy? Some
weren't. Some parts of the system had flexed because it needed to in terms of its sustainability. Some had got some creative thinking at local level. Some of that required some policy thought. So I mentioned in the presentation the look that we'd had at the sustainability of our district general hospitals. That has required us to help the local systems by producing models that look at their workforce. Again, if I give an illustration that might be helpful, we were struggling to get hospital specialists who wanted to go into district general hospitals, and when we went to speak to them, they talked about the fact that they wanted to be in a rural setting, but they were anxious about losing some of the educational and other links that that necessarily came about because they were in rural locations as opposed to big centres of excellence. We were able to work with them to develop a model of mentoring and educational links and fellowship links in some instances that allowed people to adopt rural practice and get all of the benefits out of that, whilst not feeling that they had abandoned then all of the links that they had to the great centres of excellence in the Central Belt. So some things had happened locally, and some things we developed and shared with the boards to help them see a different route to the approach that they might take to sustainable workforce.
Just about the, was there a necessity for training or retraining for new skills in terms of the workforce strategy? And if so, who took the lead in implementing that?
I think you've had a version of the workforce strategy sent to you, and in that, one of the 5 priorities was capability, and that was essentially addressing exactly the points that you've made. It was about making sure that people had an educational support where that was necessary to allow them to make the necessary changes. Some of that was driven from me and my team, and Ian Finlay might want to say something about that in a second. Some of that was driven by National Education for Scotland. We have a special health board that delivers educational solutions, sponsored through my directorate. But they work with the deans, the medical schools, the nursing colleges, the nursing universities, AHP development across the piece to make sure that we've got appropriate skills. We've also done quite a lot of work in the area of leadership and management development too, because we wanted managers to lead the NHS in Scotland who were looking for creative solutions and were happy working in an integrated space. So we've done something around that. And there's an awful lot of activity that takes place in the boards too. So we have a network of organisational development and education leads in the boards. And we've helped support them by some people from within Scottish Government and my team in terms of sharing with them the vision and helping them to craft syllabus that deliver educational excellence. Ian, I don't know if there's something that you wanted to add in that space.
Thank you. I'm Ian Finlay. I'm medical advisor to Workforce here at Scottish Government. The only thing I would add is that this is a dynamic process, and our anticipation is that we're going to need different kind of doctors now and going forward to meet the differing needs of patients. And in that respect, we're quite interested in some of the aspects of the Greenaway review, which talks about a more general doctor providing a wider range of care in the community. And we're actively exploring whether the time is right now to look at new training programs that help us blur the interface between the community and the acute hospital sector. And we're considering pilots even as we speak of that type.
Okay, can I just ask one final question? What do you feel is the importance of self-referral physiotherapy and such like in transforming the delivery of healthcare in Scotland?
If the question is targeted to self-referral for the workforce in terms of OHS and physiotherapy, then a lot, because we've got a lot around the working longer agenda. If it's about patient care, then I don't know whether you heard me at the beginning talk about our sort of triple ambition, which is safe, effective and person-centred. And we are working as hard as we can to support the population of Scotland to be healthy. So, like yourselves, we've been very thoughtful and proactive in the space of anti-smoking, minimum pricing for alcohol, obesity, exercise, the contribution of exercise to physical and mental health well-being. So we encourage patients as best we can and their carers to access services as are appropriate to them. We've had quite an interesting debate about to what extent those have to be through the gateway of a GP. And we've got a model which is emerging, which is GP-led, but not necessarily GP-delivered. So I think there's something there about how people access, and we've got a number of walk-in facilities and minor injury units that allow people to access services in that way. We've also spent a lot of time looking at extended nurse practice in that space and working with AHPs around extended practice there.
Okay, thank you.
And next, Kieran.
Thanks, Chair. Thank you very much. Good afternoon, Shirley, Ian and Grant. I detect that the answer to my question is, as has been probably given to our Chair earlier on, but it seems that your workforce vision implementation framework and plan for 2014-15, that your NHS boards and the Scottish Government have the majority of the roles and responsibilities. What is the relationship between these two bodies when it comes to workforce strategy?
The policy for workforce strategy sits with Scottish Government. We've developed that strategy with the boards, but we've also been a bit more directive in some of that. As you would expect, boards have got a very strong strategic role, but they are also in the everyday. They're also working in very sort of close timeframes sometimes. And if we look at particularly in terms of medical education, I struggle to think of anything in public planning terms other than big capital builds that takes longer than getting somebody from medical school through to a CCT and a consultant licence. So our direction there has been quite strong because we are essentially planting seeds for the whole of Scotland to harvest. So we haven't necessarily relied on boards anticipating some of those things. Those sort of 15, 20-year planning timeframes around that workforce is something where I think government has a legitimate place and probably a place that only government can do. So we work very closely with the universities. We have something called the Board for Academic Medicine in Scotland, which is essentially a board created from the 5 medical and 2 dental schools in Scotland. I meet with them on an annual basis to discuss how many people we're going to allow into the medical schools from Scotland and how that's going to operate. We're represented in that space, and we have on occasions looked at the information that we're getting from our profiling and said that the boards are not looking far enough ahead. So, for example, we've seen a significant expansion in consultants in emergency medicine in Scotland. We've been able to do that because we essentially took a view a few years ago that we were going to need more by way of consultants in emergency medicine. So it isn't a strategy that is done to the boards. We work very closely with them and try as best we can to have something that suits everybody's needs, short, medium and long term. But in strategic terms, it's probably driven more by us within government than it is specifically the boards. And of course, board management is only one group of people that make healthcare strategy come alive. We do need the cooperation of our medical schools, our colleges for nursing. We need a whole raft of different organisations. We work very closely with colleagues in education. We work very strongly to reduce inequalities in Scotland. So we're looking at things like the postcodes that we draw our medical students from. And we're working with education colleagues to see if there's more that we can do to target there. So I guess the point I'm making is that there are some things that government can do much more easily than boards can. And there's also a coherence from government that is able to knit together what 22 boards' varying positions might be and, you know, project a little bit further and think about what we might need to do in strategic terms. And that's what we try and do.
Much. That sounds that it's very important, indeed vital, that all organisations work closely together to get to the result, the end result that you want. And can I just take this opportunity to wish you all the best, and thank you very much for enlightening us this afternoon. Thank you very much. Thanks, Chair.
Thank you, Kieran. Pam, next.
Thank you, and good afternoon. Pam Cameron speaking. Thank you very much for your time today. As a committee, we have received evidence from a number of professional bodies, and one of the major issues here is recruitment and retention of healthcare staff, particularly doctors and nurses. Is this the case in Scotland? And if so, how are you addressing these issues? And for example, are you using any incentives or penalties to keep qualified staff within your jurisdiction?
Recruitment and retention is an issue for us in certain key specialties and in certain locations. The factors that make up for those recruitment and retention issues are multiple. Some of those are about work-life balance choices. We do operate a significant amount of our services on an on-call basis. We touched earlier on some of the rurality issues that make for that to be the case. We have the same kind of challenges that some of our UK brethren suffer from in terms of the sort of general dearth of certain specialties. We're being very proactive in that space, and some of that comes about because of the intelligent data that we've now got planning. So if I share with you that we now know precisely where the destinations of the kids from Scotland who go to medical schools actually are, so we know how many of them we retain in Scotland, we know how many of them have an aspiration to work on a full-time basis, or whether many of them wish to work on a part-time basis. And that's allowed us to adjust the ratios of numbers that we train in order to fill those key specialties. So, for example, we now train on a 1.6 to 1 ratio for certain of our key specialties around anaesthetics and paediatrics and so on. So, and that really is to make sure that we've got sufficient supply at the end of it. We don't currently incentivise our medical workforce with any bonuses for coming or anything like that. We have a bonding scheme for our dental students, which we use to good effect, and we now have a sufficient supply of dentists. We are thoughtful about that. We know that there are other parts of the UK that are thinking around that space, and we're not. We haven't yet reached a position on that. We don't operate any kind of disincentive to leave. We work on the principle that we try to create a working environment in Scotland that is sufficiently good that people want to participate in it. And in the vast majority of cases, that's the case. We are thoughtful about how we support people. So we have, for example, a GP returners scheme for those people who left general practice a little while ago who are seeking to come back. We have a number of initiatives about returners into the workforce that encourage people to be able to do that. And we're as creative as we're able to be in terms of talking to people about the career choices that they want to make and sending a very strong message that the NHS in Scotland values its people and wants them to continue to work with us. And that actually has generated a significant payback for us. An awful lot of people who are actually appreciative of the fact that they are appreciated. We're not perfect by any manner of means, and there are challenges around sustainability, in particularly around remote and rural. Our spread of hospitals is quite significant. I think we have 29 A&E receiving units across Scotland. Some of the rotas for those in rural Scotland are quite small, so a gap on the rota can be quite significant. If you're talking about the Southern General in Glasgow, you're talking about rotas of hundreds of people. If you're talking about some of the smaller hospitals in rural Scotland, you might be talking a rota of half a dozen. So gaps in the rotas can make a significant impact. So one of my team here works with the boards very closely to look at how rotas can be designed, how rotas are designed to be most attractive, how we support junior docs through those rotas. So we've been very creative in saying that our expectations of junior docs are that we now no longer have 7 night shifts in a row in Scotland, and we're just about to be able to say something similar about our day shifts. And it's about a message that says the workforce in Scotland is valued, and as a result of that, we want them to stay. There will be, you will have heard evidence, and I hear evidence too, of individual instances where that, you know, we have got issues and we need to try and address those. So I'm suggesting that we don't have recruitment and retention issues, because we do, but we're working very hard and creatively, I think, in that space. And that's really why we started the Everyone Matters vision with some values. Actually, in my experience, people want to work in the health service, and when we reinforce those messages, we've found that that's had generally a very positive effect.
Thank you very much.
Can I just on that ask, was the Scottish Government able to influence GP contracts?
Well, yeah, I mean, the Scottish Government has a slightly different position in respect of GP contracts, in that the GP contract was able to be negotiated with the view that it would have a 2-year window to allow us to review and look at service redesign. So my colleagues in primary care work very closely with the GPs and are just in the foothills of starting to think about what a GP contract in Scotland might look like. But that will be to reflect the changed service delivery model that we've just been discussing.
Yeah, okay, thank you for clarifying that. Joanne, next.
Sorry, Dave, I might just
Yeah,
make an
sure.
observation. There's an interesting point there in terms of the tactics about how this has worked. All of the service redesign work that we've done, we've been very upfront with all of our staff side partners that it will be the service redesign stuff that drives terms and conditions rather than the other way around. So we will design the service model that is appropriate to the needs of the people of Scotland, and then we will talk about the pounds, shillings and pence that attach to that, rather than a sort of, perhaps a more negotiated T's and C's package in the early 2000s that then left us with service issues to address.
Yeah, and I understand that, and I suppose the reason I ask is that one of the issues has been about recruitment, training and then retention, and every time the issue of retention is raised, you know, we're informed that we can't negotiate. The GP contracts are set, and I say retention in terms of GPs being trained and then actually in terms of their contractual commitment to actually deliver the service in the north here. So I'm just interested in the approach that you have taken around that, because that's a clear issue for ourselves.
Yeah, I mean, we looked quite carefully at the QOF, the quality framework that's used for GP contracts. We looked to see what it was that we wanted to buy in that space, and have tried to get ourselves into a position where we're having some very positive early discussions about how a GP contract needs to reflect the reality of how GP services are delivered in Scotland. And that isn't the same as how they're being delivered in, I don't know, Westminster or Kensington or whatever. We have to have a contract that reflects the kind of nature of practice here. We're also, whilst we're on the subject of GPs, we're also very thoughtful about some of the messages that we're getting from young GPs who are talking to us about their desire for a different kind of contract. So, you know, coming back into the vocabulary in Scotland is a much more positive discussion about the potentials around salaried GPs, for example.
Okay, thank you for that, Joanne.
Thank you, Chair. Good afternoon. I'm Joanne Dobson. Can I also thank you for your briefing? I think it's always interesting to hear from experiences in other regions, and it's something I feel we can learn so much from. We should do certainly more often. My first question would be around the majority of the health and social care workforce in Northern Ireland. Many professions is made up of women. Is this a similar case in Scotland?
I think the feminisation of the workforce in health and in our medical communities is evident, and that's also the case in our nursing communities and on our care providers. Yeah, so absolutely. There are variations in that. Ambulance service provision is still largely male, for example, but a number of our specialties are now more than 50%.
I noticed earlier, Shirley, you talk about a workforce which is flexible enough to deliver that vision. So with that in mind, did you have to take into account, whilst developing your workforce strategy, the number of women and, for example, in the terms of maternity leave and part-time working patterns?
Yeah, absolutely. I made reference earlier on to the ratios that we're currently supporting through training, and those ratios are largely predicated on the fact that women make different choices, and that we have extended training programs, for example, extended time frames for the delivery of those training programs, because people take maternity leave and come back on a part-time basis, and indeed, as an ageing population, have carer responsibilities for their parents as well as for their children increasingly, and that's not just restricted to women, obviously. So yeah, flexibility and an approach that says we should try to find, we should come at an issue with a view that we're trying to find a flexible solution. So individuals, we have a high degree of part-time working, a high degree of school contract hours, we have turn time working, we have a whole raft of provisions that allow for as much flexibility as we can. And we have to be thoughtful of that through the rotas, because we want to do that as an employer, and at the same time we know that we need to be able to deliver 24/7 services for patients. So we've worked very hard to craft rotas that allow for that flexibility and maintain appropriate levels of staffing at all times.
It was good to hear you earlier speak about the work-life balance issues, how important that was in Scotland. That takes me on to my next point, that provision of desirability of 7-day working, and one of the terms of reference for this review is examine the extent in which working planning is taking account of 7-day working. Is this an issue for Scotland, and if so, how long has it been addressed?
As I said in the beginning of the presentation, one of the messages that we've worked really hard to get over publicly in the 7-day services space is that the NHS in Scotland has always delivered a 7-day service. You know, if you have a heart attack on a Saturday, you'll get treated. It doesn't matter that it's not a Friday, sort of thing. We have had a slightly different tone in some of the 7-day services stuff in Scotland than has come from the Department of Health in England stuff. We have tried very much to make clear that we're not talking about a Tesco solution. We're not saying everything, every day, every hour of the day. We're not talking about old ladies being taken in for hip replacements at 2 o'clock in the morning and then sort of ejected out onto the street. We're talking about those things that really make a difference to the quality of care. And some of those things have been around our ability to have diagnostic tests at the weekend, and we've concentrated hard on that area. There's a whole raft of other wee bits that you'll have seen in the 7-day services plan. All of that has been mindful about the fact that we've got a workforce who have a number of aspirations. Some of them are able to extend their hours and want to do that. Some of them want to work in different ways. So Agenda for Change actually has been quite helpful in terms of the number of people who want to look at extended hours stuff. But some people simply can't do that. And we have to be mindful of that because we want to retain the people that we've got. When we started the 2020 vision, which was a few years ago now, one of the points that I needed to make routinely was that a good 90% of the workforce that we were going to have in 2020 we already had. So it wasn't enough to focus on new folk coming in. We had to produce something that was supportive of the people that we already had, the workforce that we already had, that adapted to their changing needs, adapted to the fact that our own workforce is also ageing and how we support them. So we've spent a lot of time on education training. We've also spent a lot of time on supportive occupational health. And all those kinds of things that allow people to feel that they can be fully effective at work and also have a life.
Sounds good. Thank you. Thanks, Chair.
Okay, thank you, Joanne. And George, next.
Thank you, Chair, and good afternoon, Shirley, Ian and Grant. My question would be, does Scotland have recruitment issues in particular geographical areas, such as rural locations? And if so, how was this addressed? And were any incentives used to try to recruit staff?
Yes, we do. We have some recruitment challenges in rural Scotland, particularly in the area of GPs. Ian Finlay mentioned earlier on the work that we're doing to look at the community GP training model to see if there's more that we can do in that space. We have a high use of locums. I think that's something in common with yourselves in some parts in order to maintain delivery. We're working hard to try and look at whether or not there is a salaried GP model that might help us in that space. We're also doing a lot educationally to look at how we support GPs, and we're also working very hard with our medical schools to encourage people to look at general practice in the first instance as a specialty in its own right. I know that sounds a bit perverse to say a specialty around general practice, but essentially to make sure that general practice is perceived with the same status and the same level of credence as everybody else is. We've got some rural fellowships that I might invite Ian Finlay to talk about in a bit more detail. So a lot of activity in the rural recruitment stuff. We've also been very active internationally on this space. We've been working with European colleagues through EURES to go out and spend time. We were in Amsterdam a couple of weeks ago looking at how we recruit from countries of oversupply in Europe. We are committed to ethical recruitment, so we don't go fishing in ponds of countries where they need their GP workforce as much as we do. But we've been very active internationally and actually generated a good deal of interest internationally, not least of which because most people's second language is English. So we are attracting a good deal of interest from the European Union in terms of general practitioners who may be interested in coming to work in Scotland. And we're doing some work with Education Scotland at the moment to make sure that we support them with whatever it is that they need to be able to practice to the fullest extent of their licence within Scotland. Ian, did you want to pick up the rural fellowship thing?
Yeah, just in the rural initiatives in general, about 15% of our population live in remote and rural areas. Shirley said a bit about general practice, but we've developed specific rural fellowships where people have the opportunity to train specifically to provide a wider range of services in rural areas. One of our key challenges has been the sustainability of our 6 rural general hospitals. And one of the solutions that we have recently developed has been to network these hospitals with larger urban hospitals, both for training and also for the provision of staff, and that's proved to be very successful. And finally, we've been looking at multi-skilling in the community hospitals, where our general practitioners have a wider range of skills supported by enhanced skilled non-doctors, enhanced road nurses and others in delivering the service from community hospitals, and some of these have now become non-bypass ambulances. So we've had a raft of initiatives to try and support our remote and rural services.
If I can maybe give an illustration of that to put a bit of meat on the bone of that, we have a district general hospital in Fort William, the south of the Highlands. It had some sustainability issues in terms of recruitment. It had a couple of consultant posts which had been vacant for some time. We worked with NHS Lothian, which is the Edinburgh board, which has got our biggest concentration of teaching hospitals, and asked their consultant population whether or not, if we expanded their establishment a little bit, we could put those posts into Edinburgh, those 2 vacant posts into Edinburgh, and develop with them a rota that allowed some of those consultants to go and work in Fort William. I wasn't terribly optimistic about that, but actually it worked incredibly well. number of people who are very interested in rural practice but don't actually want to commit to it full time. And we went from a situation where they'd had a couple of vacancies that they'd had for 18 months to, I think, 7 suitable applicants for those 2 posts.
Did you use any incentives to recruit staff? Maybe you already have answered that, but
George, do you want to ask it again? George, I don't know if they heard it or not.
I think we heard the question, which was, do we incentivise them in any way?
Yeah.
yes,
We
correct.
don't give any additional payments in that respect. There is a small payment for those people who operate on the island boards because it reflects the higher cost of living of some of that stuff. So there's a remote and rural island allowance, but there are no specific financial incentives to encourage people to work in rural practice at the moment.
Thank you.
Okay, and Alex?
Good afternoon. Thank you for your presentation. I'm Alec Easton. I've got good Scottish family backgrounds, just to let you know. Eastons come from Aberdeen, so there you go. My question is, given the financial climate, does Scotland have any plans for voluntary exit schemes for the healthcare workforce? And if so, how will you coordinate this with the workforce strategy and planning?
I mentioned earlier on that we currently have a no redundancy policy, no compulsory redundancy policy in Scotland. It is our intention to keep that no compulsory redundancy policy. It has served us well to be able to reassure our workforce that we're not looking to make cuts, and as a result I believe that we've reaped some flexibilities because people have not been fearful that if they're flexible they'll lose their job. The NHS Scotland pension scheme already allows for voluntary exit once somebody has reached 50 years of age. We have, as everybody has, been thoughtful about the impact of the reduction in the pension pot cap, and for our highest paid workforce it doesn't take that long actually to accrue that amount of money in your pension pot. When I was mentioning our workforce planning tools earlier on, I don't know whether you heard the bit where I was describing that we now have profiling which allows us to model. So we currently calculate an average age of retirement from the NHS at 61, but that allows us to model for workforce that works to 65 or indeed 55, and we're therefore able to predict where we think we may have bulges or under supply, and essentially turn the tap on a bit further upstream to make sure that we've got sufficient of the workforce coming through in that respect. It's not our view that we would be looking to any large-scale voluntary severance package available for the NHS at the moment. Our efforts are much more around encouraging our workforce to stay with us, to continue to work with us healthily and happily for as long as they can. But the pension scheme that we operate already gives that voluntary severance exit through the pension route from the age of 50. I haven't actually seen a massive growth in that in the last wee while. In fact, the contrary has been true. We've found that actually the number of people who are wishing to carry on working beyond 65 is growing. And when we're asking people the reasons for that, they're citing some of the economic challenges that family members and others may be facing. So we haven't had the huge mass exodus that we might have thought we were going to have with the pension stuff.
Thank you.
Okay, well, just finally then, just interested generally if the reconfiguration of your system, if you like, if your model of delivery for health from the 28 trusts to the 14 boards, I think I'm right in saying that, has that assisted in terms of responding to workforce planning needs and requirements?
Immeasurably.
At what, sorry?
Immeasurably.
I didn't get that.
Absolutely.
Because that's just that's one of the things that we find in relation to our system here, that we're interested in pursuing with yourselves. The shift in Scotland to the cooperative traditional NHS model seems to be closer to providing a system that can strategically respond.
Yeah, if I reflect on what it used to be like when we had primary care trusts and acute trusts, there is no doubt that we spent a bit of time trying to make those two systems talk to each other. In the formation of the 14 territorial boards that we currently operate, those relationships work better. So when we're talking to boards about their ability to workforce plan, I don't have to talk to them about a separate thing that is primary care from the acute sector. When we're talking about service models, we're talking about how we flex the workforce to do that. So we've got GPs who work in hospitals sometimes. We've got consultants who go out into primary care parts of the estate. So we're delivering services. We've got nurses who work across those boundaries. So we're working across the estate in a much more intelligent kind of way that means that boundaries that don't need to exist aren't. And that, I think, has helped us immeasurably. It also means, frankly, that we're talking about 14 workforce plans, which is manageable for us, as opposed to 20 or 30 or 50 or however many. So for us, it's become a much more manageable exercise. It's much easier for us to spot risk. So when those workforce plans come in, my team look at them from all of the lenses, workforce planning being one of them, but pay risks or staff governance risks or whatever it is that we're particularly interested in, they're looked at through every workforce lens. We can do that because there's 14 of them. If there was 50 of them, that would be a hell of a lot harder. And it would be much harder to identify issues that we need to be thoughtful about. So yeah, immeasurably improved by the reconfiguration into the existing board structure.
Thank you, all three of you, for today. Certainly that has been extremely useful and clear for us and going forward, and obviously we will be reflecting on the evidence that you've given us today in terms of our inquiry going forward, and we would hope that we would be able to come up with some, I suppose, clear recommendations that will be about reform in terms of the delivery of the service around workforce planning. So I thank all three of you for taking the time, and we certainly look forward to continuing this cooperation and collaboration. Thank you.
If I may thank you for the very great privilege of being able to speak with you this afternoon. It's always great to share information. We don't have all of the answers. In fact, some of the time we don't have all of the questions. But we are very happy to help in whatever way that you think, and it's also a very great opportunity to us to learn from of yourselves. So thank you very much indeed for giving us the privilege of being able to speak with you.
Thank you. Okay, members, thank you for that. Item 5, members, has been dealt with in under Chair's business, the core funding for the community and voluntary sector. Item 6 is the forward work programme. Just want to refer members to that at page 100 of your meeting folder. And I just want to ask members to note the forward work programme at this point. 7 is matters arising. There's 4 items under matters arising at page 101 of your meeting folder. Page 102, item 7.1 is the response from the Minister in relation to the draft adult safeguarding policy. Members will remember this was subject to an evidence session in terms of particular legislation that was required to define and protect our elderly community, particularly from abuse. And there was a disparity of views expressed in the consultation in relation to whether legislation is actually necessary. But I think as a result of the committee querying this further, both Ministers Hamilton and Ford have now said they wish to take more time to consider the range of views and to try to reconcile them. So I'm asking members at this point just to note that is the case at this point. Page 105 is response from the Minister in relation to suicide prevention. Again, members, I'm seeking agreement to forward the response to suicide down to zero, who had raised the issue with the committee. Page 109 is a response from the Minister in relation to the Patient and Client Council, the HSC online user feedback system. Again, seeking agreement to forward the response to Patient and Client Council, who raised the issue. And are members content to note the remaining responses?
Right.
Item 8 is correspondence. 3 items of correspondence at page 110 of the meeting folder. Are members content to note?
Yeah.
Yep.
Any other business? Do members have any other business?
Yeah, Chair. Could I raise the problem of during the week since our last meeting, there was a circular, an unsigned circular, distributed to people with learning disabilities. You may have heard me raise it somewhere earlier on this week in relation to the change in policy regarding continence products. And this is a regional agreement whereby they're proposing to allow four pads in a 24-hour period. And if you need, now this is people with learning disability, if you need any more, you're going to have to pay for them. That affects everyone in Northern Ireland in relation to this new policy. Could I propose that we write to the department or the board objecting to this, because undoubtedly it will affect the well-being and health of people with learning disabilities, in that they're going to have to sit longer periods in soiled clothing and wheelchairs and ending up with broken skin, etc., 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 and it's totally unacceptable. I'm sure everybody would agree with that.
Well, I've no issue with raising it with the department. I'm mindful that it's not a signed letter,
not a
but I
signed
think
letter,
in terms of the issue, we should seek clarification from the department in terms of that, if there has been a shift in policy direction. But happy to do that, Kieran.
Aye, thank you.
Do members have any other items of business? No. Item 10 then is date, time and place of next meeting, which is on Wednesday the 17th of June, starting at 2 o'clock in the Senate chamber. There will be a pre-meeting at 1:30 in room 55, which is the education room just across from the Senate, just to go through the 2 briefing sessions. Thank you, members, and thank you for your cooperation today.
Northern Ireland Assembly Committee Room